I will be performing an assessment, a head-to-toe assessment on my volunteer patient who has graciously volunteered her time to help me out with this. So, before entering my room, I've made sure that I have all the tools necessary to perform my head-to-toe assessment and will now enter the patient's room. Upon entering the patient's room, I will introduce myself to her. Hello, my name is Brian. I'm going to be your nurse today. I'm going to be performing a head-to-toe assessment. Do I have your permission to perform that assessment?
Yes.
After getting permission from the patient, I'm going to go ahead and provide privacy by closing the curtains and shades, and I'm also going to perform my hand hygiene. Before I start my head-to-toe assessment, I'm going to get a quick background and health history on the patient. And first, I'm also going to identify the patient. So, I'm going to look at the patient's armband, which has her name and date of birth. Can you please tell me your name and date of birth?
CM 112490.
The patient has appropriately identified herself based off of the information on her band, so I will continue. And again, getting a quick overview of her pertinent history. Are you currently taking any medication?
Yes.
What are you taking?
Birth control.
The reason for the birth control?
A hormonal imbalance. I have polycystic ovarian syndrome.
And how long have you been taking the birth control for?
Since I was 16 years old.
Do you take any other medication?
I take antacids for my acid reflux.
Okay. Anything prescribed or just over the counter?
Over the counter.
Over the counter. Now, any pertinent or family history? Diabetes, high blood pressure, high cholesterol?
Diabetes, my paternal grandfather and my maternal grandmother and my uncle and my sister.
How about high blood pressure?
My mother has high blood pressure.
Okay. And high cholesterol?
No one in my family has high cholesterol.
Any family history of cancer?
My uncle had liver and pancreatic cancer, and I think that's it.
Do you have any health concerns going on today? Any aches and pains you want to disclose before we start?
No.
Okay. So I'm going to go ahead and grab my base set of vitals. I do not have an actual blood pressure cuff with me, but if I did, I would attach it around the brachial artery indicated by the line to match up with the artery. I would inflate the cuff, and using my stethoscope, I would listen to the point where I no longer hear a heartbeat and go slightly past that, deflating the cuff. I would listen for the first heartbeat being my systolic and listen for the final heartbeat, which would be my diastolic. In this case, for this assessment, the patient's blood pressure was assessed at 126/84. I'm also now going to get a oxygen saturation by placing this on the patient's finger. And the oxygen saturation that I get is 100%. I'm going to go ahead and do a manual pulse, a radial pulse. And I'm going to do this for a total of 1 minute, 30 seconds. I will be doing a feel for rate and rhythm of the pulse. And again, what I'm assessing here is the rate and the rhythm, which is regular and strong. And the number I got for the 30 seconds was 40. I will multiply that by 2 and get a heart rate of 80 beats per minute. And for the remainder of the 30 seconds of the minute, I will be visually inspecting the patient's chest for rise and fall during inspiration, and also doing a quick visual inspection of any kind of abnormalities I can see on the skin, face, posture, and anything else I see. At the moment, I see no irregularities, and that concludes my 1 minute. We will take a temperature orally, and for the sake of this assessment, her temperature was an oral reading of 97.9. The patient currently stands at 5 feet 5 inches, is a 29-year-old female, Hispanic, married, and weighs 230 pounds. We've gone over her health history, which she has disclosed to us. I'm going to go ahead and start off my assessment for the head to toe. Starting off with her head, I would be wearing gloves to go ahead and do a palpation of her scalp and head and face. So please let me know if you have any pain or tenderness on palpation. Anything at all?
No.
I'm going to be pressing on the sinuses. Any pain or tenderness?
No.
No. Upon inspection, I would also be parting the hair to inspect the scalp as best as possible. Upon my inspection, the patient has some dry scalp, flaking skin, and some irritation submerges around the hairline. Patient has no visible swelling around her face, or eyes, or anywhere else on this inspection. I'm going to go ahead and put pressure on the joint of the mandible, and if you wouldn't mind opening and closing. What I'm doing here is feeling for any clicking, any locking of the jaw, which she has none. Good. Alright. And I note no swelling of the eyes, of the eyelids, appropriate hair of the eyelashes and eyebrows. I'm going to go ahead and move now to my inspection of the patient's eyes. On visual inspection, she has no redness. Her eyes, her pupils look equal and round. Looks like she has no irritation. Again, no swelling. So what I'm going to do for this test is I'm going to shine a light in each eye individually, and that's checking for the reaction to your pupils. Your pupils in the presence of light should dilate, or should restrict, I'm sorry, and then dilate in the presence of less light. So looking at me, I'm just going to cover one side and shine my light here, checking for constriction of the pupil, which she does have appropriately on the left side, and appropriately on the right side. So she has an equal reaction bilaterally to the presence of light. I did see that you do have glasses. Do you use those for distance reading or for both?
For both.
For both, okay. Now what I'm going to have you do is I'm going to have you track this pen light without moving your head and just your eyes. Okay. And what I'm doing is checking for any irregular movement of the eyes, any inability to track the pen without movement of the head. And again, follow and follow. Good. All right. And now what I'm going to do is I'm going to do a visual inspection of her ears bilaterally. So first, looking at the ear, I'm going to be feeling and applying some pressure. Any pain or discomfort?
No.
No. I'm looking at the skin of the ear, behind the ear for any irritations, any ulcerations, any kind of signs of abnormalities, which this patient has none. Now doing a visual inspection, I see the tympanic membrane, and it is reflective of light and a grayish pearl color. On the right side, I will do the same for the left side. Again, applying pressure, seeing for any redness, any irritation of the ear or behind the ear, which I see none. And again, checking inside the ear canal. And equally with this ear, I see no occlusion, no blockages. I can see the tympanic membrane, and it is appropriately colored of gray pearl white. And I do see reflection of light. What I'm going to do now is I'm going to go ahead and inspect your nose. So if you can tilt your head back, and in shining the light and looking at the nasal passages and the nares, I'm looking for any signs of polyps, deviation, discharge, anything that would be abnormal, which the patient has none. You can go ahead and put your head down. And moving forward, I'm going to go ahead and assess your mouth. On visual inspection, I'm taking a look at the color of her lips, any pallor, any grayness, any chapped lips, any signs of dehydration. Her lips are appropriately colored, they look moist, and they have no cracks in them. If you wouldn't mind, please opening your mouth and sticking out your tongue. The tongue is appropriately colored, it's not a beefy red, and I'm inspecting the mucosal membranes around inside the mouth, and if you wouldn't mind lifting up your tongue And what I'm looking for is any signs of ulcerations, discoloration, anything of that nature, any dryness, and there were no abnormal findings on this patient at this time. I'm now going to inspect the patient's neck, and on visual inspection, I'm going to go ahead and see that she has a midline trachea, no swelling, no bumps, no signs of goiter, or anything that may indicate a thyroid issue. And now I'm going to palpate her glands. Any pain or discomfort with palpating your glands at all?
No.
Any difficulty swallowing?
No.
No. So normal findings on this patient at this time. I'm now going to go ahead and move down to a actually before that I'm going to assess the patient for range of motion of her neck. So if you would please look down, look up, move your head side to side, and then look left and look right. Any dizziness with any of that movement, any difficulty with any of that movement?
No.
No pain or discomfort at all?
No.
Good. Now what I'm going to do is I'm going to go ahead and assess her upper extremities. Ideally she would be in a gown and I would have more exposed skin to be able to view all areas of her skin. In this situation I do not, so I will go ahead and say that I do not see any abnormalities in her skin at this time. I'm going to go ahead and have the patient squeeze both of my hands as strong as she can. Good. And she has equal strength in both sides. And now push against my hands. Good. Now I'm going to try to push down. Don't let me. Good. So she has equal strength in both hands. And I'm now going to go ahead and assess her capillary refill on both hands. And while I'm assessing capillary refill, I'm seeing for any issues in joints, any swelling, any discoloration, which I see none at this point. And doing the same on this hand while doing the capillary refill. Trying to cluster my assessments as much as possible. And again, no abnormal findings on this patient. Her capillary refill is equal to or less than 3 seconds on both hands. Now I'm going to go ahead and have the patient stand for me. Thank you. Now if you wouldn't mind arching your back backwards. Any pain or discomfort?
No.
No. Now bending forward at the waist and attempting to touch your toes. Any pain or discomfort?
No.
Good. While the patient's standing, I'm going to go ahead and assess her lung sounds. Have you had any issues in the past with asthma, bronchitis, anything like that?
I've had bronchitis before.
Okay. How recently?
It's been like 6 years.
Good. So I'm going to have the patient take deep breaths in, starting with the left upper lobe. Good. Moving over to the right upper lobe. Going down the right side to the mid. Moving over directly to the left at the same level. Moving down on the left for the lower lobe and moving across at the same level for the right. And during this assessment, what I'm listening for is for any stridor, wheezing, or any signs of respiratory issues or consolidation of the lobes, which at this point I hear none for the patient. Everything is clear upon auscultation. You can go ahead and have a seat. What I will do now is check the patient's upper extremities for tactile sensation with a sharp, soft, dull, and a dull item. There we go. So, if you could please do me a favor, close your eyes. I'm going to touch you with either a sharp, dull, or soft item. And I can promise you that the sharp item will not cut you. Tell me where I'm touching you with the item and what sensation you feel.
My left cheek is sharp.
Good.
Right cheek is sharp.
Good.
Left cheek is soft. Right cheek, it's soft.
Good.
Left cheek, it's dull. Right cheek, it's dull.
And continuing on with the extremities.
Left arm, it's sharp. Right arm, sharp. Left arm, it's soft. Right arm is soft. Left arm, it's dull. Right arm, it's dull.
Good. And now I'll move on to the lower extremities, doing the same thing.
Left leg, it's sharp.
Good.
Right leg is sharp. Left leg, it's soft or dull.
No, you let me know.
I'm gonna say dull. Right leg is dull.
And this would be appropriately done on skin, so I'm just gonna lift this up.
Left, it's soft. Right, it's soft.
And then while I'm down here doing the sensory test for the lower extremities, I'm gonna go ahead and do a quick visual inspection on the lower extremities. Again, checking for any swelling, any discoloration of the skin, which at this time I see none. You can go ahead and open your eyes. I'm going to go ahead and palpate for a dorsal pulse or a pedal pulse. And I feel the pulse is strong. Checking again for a pulse, which is strong. At the same time, I'm going to be pressing down and letting the skin come back and see if there's any edema, which there is none at this time. Pinching the skin for any tenting, which there is none at this time. And while I'm on this foot, and she has mentioned that she has a family history of diabetes, I will be checking for any kind of neuropathy or lack of sensation. So again, close your eyes and please tell me when you feel that I'm touching the bottom of your foot.
I feel that.
Good.
I feel that.
Good.
I feel that.
Good.
I feel that.
Sorry. Good.
I feel that.
Good.
I feel that.
Good. And while I have the patient's foot up here, I would take off the sock and I will check for any discoloration, ulceration between the toes or at the bottom of the foot, which she has none at this time. And I will proceed to go on to the right foot and do the same assessment. So I'm checking for the pulses, which are present and strong. Good. Pulses again, which are present and strong. And at the same time, again, checking for any kind of edema by pushing down on the skin and seeing if there's any indentation left, which there is none. The skin rebounds appropriately. And checking for tenting and any signs of dehydration, which she has none. Now please let me know when you feel when I touch your foot.
I feel that.
Good.
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 I feel that.
Good. And again, checking the foot and the skin between the toes and on the bottom of the foot for any signs of ulceration or wounds that may not appropriately heal if she does in fact develop diabetes or because she is in fact pre-diabetic at this time. Alright. And again, with the foot assessment, I'm going to be pushing down, providing resistance, push against it. Good. Her strength is equal bilaterally. And now don't let me pull up. Good. Alright. Now, what I did fail to do on my exam for the respiratory, which I should have gone and done at the same time for time purposes, but I'll do it now, is I'm going to place my hands on the patient's back and have her take a deep breath in. Feeling for equal expansion. One more time. And now what I'm going to have the patient do, I'm going to check for tactile fremitus, which is to see if there's any consolidation of any of the lobes of the lungs by putting my hands on her back, moving down and having her repeat the phrase 99.
99, 99, 99, 99.
Good. And I will do the same thing in the front, feeling the rise of her chest with inhalation and expiration going down symmetrically, bilaterally. Okay, and if you could do me a favor, 99 again.
99, 99, 99,
And then lift up your arms and say 99 again
99,
and again.
99.
Good. So there are no signs of any kind of consolidation in the patient's lungs. They are clear upon auscultations, and the patient disclosed that she has had bronchitis 6 years in the past and has not had an issue since. Now what I'm going to move on to is the assessment of her abdomen. So I'm going to have the patient lie down. And ideally in this aspect I would have the patient's abdomen exposed, showing her skin, and I would do a quick visual assessment to make sure that everything is midline where it should be, as well as assessing the skin for any changes, any cuts, lacerations, bruises, surgical sites. In this patient's case, she did have a laparoscopic biopsy for endometriosis recently and has 3 small incisions at the navel and 2 on the side, which were held up with steri strips, so there's no real indication of stitching going on. Other than that, the patient's abdomen is free of any other abnormalities. What I will do as well is note that there are no bulging, no signs of any herniation at this point in time. Now what I'm going to do after I looked is I'm going to listen. So I'm going to auscultate all 4 quadrants of the abdomen for bowel sounds. And I'll be doing this for 30 seconds in each quadrant. Listening for bowel sounds. And after auscultation, I have identified that there are bowel sounds in all 4 quadrants of the patient's abdomen. Now I'm going to move on to percussion. And the percussion is to identify any points that would indicate resonance that should not be there, which be indicative of any swelling of internal organs or obstructions where they should not be. And for safe measure, I'll do it one more time. Good. Now what I'm going to move on to after I looked and listened and percussed, I'm going to go ahead and do palpation. And what I'm looking for here while I palpate and ask the patient if she has any pain is looking at any nonverbal cues, which would include grimacing or guarding that the patient may not identify directly towards me. Any pain or discomfort here?
No.
Pain and discomfort here?
No.
Any pain and discomfort here?
No.
Have you had any issues with your bowel movements?
No.
Have you had any issues urinating?
No.
Okay. And now I'll have the patient sit up and return to her chair.
Ooh, almost fell.
And after doing my head-to-toe assessment, I will document everything that I've found, including a report on the patient's pertinent past medical history and family history, and I will send the report to the provider for their assessment. And that concludes our head-to-toe assessment today. Thank you.